Support for this program is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. There's more to explore. Discover all the data at vabysmo-hcp.com. That's VABYSMO-HCP.com.
Welcome to the new Retina Radio Journal Club with VBS. My name is David Xu from Wills Eye Hospital in Philadelphia, and today I'm joined by Dr. Barton Blackorby from Sound Retina of Tacoma, Washington.
Hey, great to be here.
And also Dr. Prethy Rao from Retina and Vitreous of Texas.
Hey, everyone.
And so the paper we're going to be talking about is primary retinal detachment repair in eyes deemed high risk for proliferative vitreoretinopathy, surgical outcomes in 389 eyes, written by Dr. Salabati. And this is a very interesting paper, and it hits on obviously a really important topic in our field, the repair of rhegmatogenous retinal detachment. I'm going to hand it over to you, Barton, first, if you don't mind. Could you give us a rundown of what the key points of the paper are?
So this paper focused on a retrospective consecutive case cohort study of patients seen at the Wills Eye Hospital from 2016 to 2017. And what they looked at were patients who had retinal detachments exhibiting high-risk indicators for PVR, and they were fixed either with a vitrectomy or a buccal vit. And these high-risk indicators were preoperative PVR grade A or B, presence of a vitreous hemorrhage, large retinal detachments, over 50% of the retina, and those associated with 3 or more breaks, having a history of cryotherapy, having a history of choroidal detachment, or a detachment that's been there for over 2 weeks. And originally they had around 2,000 records, but they were able to whittle those down to about 389 that met the definitions. In about a third of those cases, a buccal vit was performed, and in 2/3, a vitrectomy alone was performed. And what they found was that the single surgical attachment success rate at 3 months for all patients was about 72%. Those within the buccal vit cohort was about 81%. PVB alone was about 67%. And they found the difference in success rates to be statistically significant. And when they looked at this in a multivariate analysis, they really didn't find any correlation between any high-risk features and surgical failure. The only surgical method used was able to explain the difference in the success rates between the groups. So they concluded that for patients with high-risk PVR, a combined vitrectomy buccal may lead to better outcomes than a vitrectomy alone.
And then Preeti, what's your take on all of this? Does this pass the gut check for you based on the results that they're finding? Does it line up with your clinical experience?
Yeah, first of all, this was a great paper. I really commend, the Wills Eye group in tackling a tough topic because, obviously we want to have our kind of simple, non-complex RDs and have kind of our best outcomes, but to look at kind of this more elusive PVR kind of monster is a tough thing to tackle. I think, I think these results are very consistent with standard practice, like, buccal vit compared to vitrectomy, having a higher success rate. I think it's hard, though, because the study design is retrospective in nature, and essentially it's observational. It's what surgeons have done, and can we tease these answers apart? And so, there's definitely, multi-surgeons and a lot of different surgeons involved. And with that, comes our separate biases with how we want to treat, and pick and choose our cases. And you can see that kind of in the study where, those that tended to be MAC off, those that tend to be phakic, those that tend to have, a larger retinal detachment greater than 50%, buccal vits were favored. But, I think a lot of people, would be definitely in that cohort as well in terms of surgeon preference.
And I know these are direct colleagues of mine, so I hope I don't get into any hot water, but what do you think about the inclusion criteria, specifically the definitions of high-risk PVR eyes, Barton? I mean, do you agree with that?
I do, and I'm glad that they stopped at PVR grade B. Once you get into grade C and D, now you're getting more that broad preretinal fibrosis, which really can affect your surgical outcome and have to do more advanced maneuvers like a retinectomy. And I think that would really cloud the outcomes of the study. But all of the things they have listed there are either, pro-release of RPE cells leading to PVR, pro-inflammatory mediators such as in vitreous hemorrhages, choroidal detachments, things like that. So I think they really identified the true risk factors for PVR development.
And I thought one little point, and I think it deserves a lot more attention, I think, than maybe what the paper had even given it, which is the breakdown on the age, both above the age of 65 and below the age of 65, where they detected differences at a younger age, but not necessarily in the cohort in the older population. I thought that was interesting, and I thought that was, potentially something that is elucidating, and correlates to the mechanism of retinal detachment. What's your take on that, guys? I mean, is that something that you agree with? Do you add more buckles on younger patients? I mean, what's your thinking on that?
Yes, for me. I think their vitreous, there's a lot more formed. And I think it was very conservative cut point, greater than 65, less than 65. I bet you'd find bigger differences if you broke it down to less than 30, 30 to 50, even less than 18. So I think it's very consistent to what we see in practice, with younger patients having more formed vitreous, higher PVR risk, et cetera.
The better vitrectomy that I can do, especially in a pseudophakic eye, might not put a buckle on. A younger patient, most likely going to be more phakic. I'm going to need that extra support. They're also going to have to live with this for much longer than an older patient. So I want to make sure they have the support, carried on beyond what, the other cohort might have had.
Wonderful. Well, thank you for this discussion. We're going to head into a brief break, and then we'll return with a more in-depth discussion on the other side.
Support for this program is brought to you by Genentech, the makers of Vabysmo, faricimab SVOA. There's more to explore. Discover all the data at vabysmo-hcp.com. That's VABYSMO-HCP.com.
Welcome back to the New Retina Radio Journal Club with VBS. Now, let's get into a longer discussion about the paper that Dr. Blackorby nicely summarized. So we are going to, I'm going to kick it back to you, Barton. I'm just going to ask you, we, in light of the findings here with respect to, buccal vitrectomy, I mean, what do you think are some of the mechanisms surgically that make this procedure a more successful procedure?
So I'm a big fan of buccal vits. And in fellowship, I was exposed to a pivotal paper. So I'm going to go way back here to a paper from 1984 by Robert McNamara. It was the Edward Jackson Memorial Lecture. And basically what he talked about is that you need three things to create a detachment. You need a hole in the retina, you need a current to get fluid under the retina, but then you need traction, whether that's the vitreous, gravity, or fibrosis like PVR. And if you get rid of at least one of those, you're not going to have a detachment. And we see that, when we have silicone oil and scleral buckles and everything where we can modify those risk factors. And I think adding a scleral buckle takes away that tractional component, because even if you are going to get PVR, you've now changed the peripheral nature of the eye. You've supported that hole. So you still have current, you still have a hole. Dr. McNamara even argued that you don't even need a chorioretinal scar, because once you've gotten rid of that third component, it won't redetach. And I think that's why our success is better with buccal vits, because we have that support from the buccal. We're taking away the future traction from progressive PVR.
And then I'm going to ask a question to both of you. What are your thoughts as to why a buccal vit, at least according to some papers that were recently released, for example, the PRO studies and a variety of other retrospective in nature studies, but the idea that a buccal in supplemental buccal with buccal vitrectomy helps in phakic patients, but not as much in pseudophakic patients. Mm-hmm. How does that equation change with what Dr. McNamara had talked about, or you're thinking about these things?
I think it supports what Dr. Mockmer has been saying, is that you're redistributing the tractional forces. I mean, in phakic patients, as we all know, it's harder to trim that vitreous base peripherally. And phakic patients tend to be younger, so their vitreous is more formed. So the difficulty is being able to lift that PVD all the way out to as far as possible. And so in those patients where you're worried about their base, especially in younger patients that also tend to maybe have a posterior vitreous base or a posterior insertion of their base, that buckle really helps redirect those forces much better than we can by shaving every tendril of vitreous out there in collagen fiber.
And do you think that the factors that were studied in this study, which are heterogeneous in any retinal detachment, the authors really did a lot. They measured how much vitreous hemorrhage, all these different factors about the extent and the anatomy of the retinal detachment. Do you think that can adequately capture the individual variability that really contributes to this meaningful finding that buccal vitrectomies were superior in this population?
I think that the more risk factors that you see preoperatively, the more that I would go in thinking that this isn't going to be as straightforward as I think it will be, that this patient is more high risk. As Dr. Rao had mentioned, when we look at some of these multi-surgeon studies, it's difficult sometimes. You have an individual approach and you have individual surgeons with their skills. But I think what the paper, their overall theme shows is that the more of those risk factors, the more that you have to get more aggressive in your approach, because it may not be as straightforward as, that typical pseudophakic one break superiorly.
I agree 100%. What's kind of interesting about the paper, though, is when they break down into number of high risk factors, like none of them, whether you had 1, 2, or 3, the success rate was the same, which I found like super interesting. And then begs the question of, are we identifying all the risk factors for PVR? Are we identifying all the right combination of risk factors for PVR? And what's kind of the magic sauce of promoting PVR? So that's kind of interesting. I would have loved to see them kind of break it down based on vitrectomy versus buccal vit, and look at maybe 1, 2, or 3 of the risk factors and maybe trying different permutations or combinations and see if that made a difference. So that was very interesting that it was, the success rate was pretty high and no different.
And I'd even add to exactly what you just said there, that each one of those high-risk features is the presence of chronicity equivalent in terms of risk. Is that worth the same number of points of risk as preoperative vitreous hemorrhage versus having, prior failed cryotherapy versus having greater than 3 retinal breaks? Are all of those things the equal risk? And I think that it ties into this idea that we don't really have a risk stratification or points-based system for evaluating preoperative risk for retinal detachment, which is literally one of the most common diseases that we deal with in vitreoretinal surgery. I think it goes to just show how difficult a task that has historically been.
Mm-hmm.
It's definitely an area of exploration that, we at Wills and my colleagues here included are very interested in this topic, of course. All right. Well, thank you, Prethy, and thank you, Barton, for making this discussion happen and summarizing this wonderful paper. Really appreciate it. And thank you to the audience for tuning in.